Welcome. Thank you, everybody, for your interest in our International Development Week panel presentation. We are a little ahead of the curve as International Development Week starts next week, but we're kicking it off today. Just a couple of things about how this panel discussion will work. We will be moderated by our diocesan representative from the Diocese of Ontario, Sophie Kawala. I'll give her an introduction in a second. And we have partners from three of our international partners with the All Mothers and Children Count COVID extension projects, from Diocese of Masasi, from Village Health Works, and from EHALE, and Sophie will give them a warm introduction, as well as our colleague Bart Dickinson. So thank you all. We are scheduled to go for 90 minutes, and we have set it so that the chat, you can ask questions. It will be seen by those of us that are hosts and co-hosts. And so we will be monitoring that chat for questions. We'll have a couple of spots where we can, answer some of your questions. But for the most part, we do have a fairly large group of people registered, and so we'll not be having the opportunity to have verbal questions by unmuting. So just please do, as you have your questions, type them into the chat, and Janice and Sophie will be monitoring that. Want to also introduce Elizabeth Tuck from the Ontario Council for International Cooperation. She will be working with us today, as this is kind of, we are working in partnership with Ontario, with OCIC, and this panel discussion is part of their Global Citizens Forum. So thank you, Elizabeth, for joining us, and thank you to your colleagues for joining us as well. So I will now introduce Sophie. Sophie Kawala is the diocesan representative from the Diocese of Ontario. She was appointed in 2020. She was a member of provincial parliament for Kingston and Islands from 2014 to 18. Prior to that, she's worked in federal constituency offices as manager and chief of staff. And prior to that, she was an entrepreneur. She has lived in Turkey and France for 5 years. She has degrees in politics from Athabasca and Queen's University, and is currently working on her professional master's in public administration. Sophie is a tireless community advocate who is passionate about supporting vulnerable sectors of society and Indigenous reconciliation. So thank you, Sophie, and I'll turn it over to you.
Thank you so much, Kim, and warm welcome to everybody who's here today. And I have noticed on our screen that we do have Bishop Francisco Silva all the way from Brazil. So this is really exciting. I'm going to start today's session with the traditional acknowledgement, and I will speak to the traditional acknowledgement from the territory that I am speaking from here in Kingston, Ontario. We acknowledge the traditional territory upon we gather to worship as that of the Anishinaabe, Haudenosaunee, and the Huron-Wendat peoples who have sought to walk gently on this land for thousands of years. We seek a new relationship with the original peoples of this land, one based on honor and deep respect. And to that end, I do want to say that in paying respect to our Indigenous heritage and culture, we bring our good minds and hearts forward today as we engage in this discussion and journey of learning, guided by our incredible guests from our partners in other parts of the world. So this is very exciting. Our furthest partner in the world is is from Mozambique, a long 13,172 kilometers from here. So welcome, everyone. I'm going to lead into the general introduction, and then following that, we will go to each of our panelists, each of our 4 panelists for the questions. And we're going to keep a fairly tight time frame so that we can have some time for questions at the end. For the past 2 years, PWRDF, together with its partners in Burundi, Mozambique, Rwanda, and Tanzania, and with support from Global Affairs Canada, has carried out 2 one-year projects that have responded to the global pandemic that is COVID-19, something we know well. Designed to maintain the gains achieved through the 4-year GAC-funded All Mothers and Children Count program, these projects have supported vital COVID-19 related work. In this webinar, marking International Development Week, PWRDF's Planning, Monitoring, and Evaluation Coordinator, Bart Dickinson, witness Gerald Mushi of the Diocese of Masasi, Tanzania, Ramula Issa, EHALE, Mozambique, and Melchiade Ninganza from the Village Health Works, Burundi, will explore the impacts of COVID-19 through the data that they have gathered and through real-life experiences on the ground. That's what makes this session so important. They will discuss how this has both made possible new work and challenged existing ways of working. And they will explore how COVID has changed the way we live out our our partnerships. So thank you so much. This is just an exciting opportunity. And I'm just going to go over to my questions. The first question is going to be for Bart. So thank you, Bart, for being with us. Sorry, let me just flip over here. Okay. All right, Bart, welcome.
Thank you.
What is the lay of the land vis-a-vis COVID from a high-level statistical point of view in the countries where we have carried out the Amcc extension? And each response will have about 2.5 minutes. So keep that in mind.
Yeah. So it's really interesting. Just first of all, hi, my name is Bart Dickinson. I'm the Planning, Monitoring, and Evaluation Coordinator for the Primates World Relief and Development Fund, or PWRDF. I'm joining you from the Ottawa Valley, traditional unceded territory of the Algonquin Anishinaabe. My pronouns are he, him. And thank you so much, everybody, for joining today. And hopefully today we can take a chance, take a step back and reflect on what maintaining results looks like in light of the pandemic. And rather than approach this didactically, we wanted to have an open, unstructured kind of conversation with 3 incredible practitioners living in the field who I'm so glad to see here today. I think to your question, Sophie, it's really interesting. When we look at COVID-19, the prevalence, say here in Canada, we can already see, issues and challenges with access to testing, people being able to get tested. And I remember at the beginning of the pandemic, there was a lot of literature about how Africa was somehow untouched by the pandemic, that they're doing so much better. And a lot of people, even today, we think about how challenging it is to say, get a rapid antigen test. At that very inceptive phase in Africa, they didn't have any testing. So of course their numbers looked great because there was nobody actually measuring that at that point in time. But we were at that point in time, I think, just as a collective humanity, looking for any best practices and solutions. And that's sort of been the exercise of operating during the COVID-19 pandemic. The statistical modeling in a lot of these countries for measuring the prevalence and the impact and the spread of the pandemic has been very different, using sampling methodologies with smaller communities to isolate whether or not the pandemic is prevalent in very rural areas, but it's not like voluntary universal testing. It's sampling. It's done using statistical modeling, and when we look at the numbers, they're still very much being hit very badly by the pandemic. That having been said, there are demographic differences, significantly younger populations, and also a history of living with endemic challenges like malaria, or combating, say, the Ebola virus as well. That I think has people in the global South and in Africa in particular more primed and used to kind of working or managing their lives around the incidence of something like this. That having been said, Omicron is spreading through many of these countries, and when we look at the Canadian context, we often will compare ourselves south of the border, and we think, wow, what a vastly different context that we're looking at, just so close to us. And what you'll see today from our three collaborators here is vastly different contexts within the African context as well. So I'm really hoping and looking forward to hearing from our partners on what the statistical burden looks like in their countries from their own perspective.
Thank you so much, Bart. I appreciate that. And thank you for introducing yourself. I apologize. I've been shuffling some papers here this morning, trying to keep things in order. This is really exciting. We certainly appreciate your role enormously in the planning, monitoring, and evaluating of our programs, and your insight in today's program is really quite appreciated. So our next panelist is witness Gerald Mushi. She is the gender officer from the Anglican Diocese of Masasi in Tanzania. Witness has worked closely on the All Mothers and Children Count program implemented by the Anglican Church of Tanzania, Diocese of Masasi, and the gender focal person for diocesan operations. She has 6 years experience in the field of supporting mothers and children's health with a focus on gender sensitivity and special needs. So witness, my question to you, which will be the same for the other two partners coming up, is what has COVID looked like on the ground in the communities you have carried out the AMCC extension? So, and again, you have about 2.5 minutes for your reply. Thank you.
Thank you, Sophie. I'm glad that I've got the opportunity to join here. I'll start responding the questions starting from the national level, then I'll be coming to, then I'll narrow down to our community we're working with. As you know that Tanzania has two paradigms in responding to COVID-19. The first paradigm under the late John Pombe Magufuli, and the second paradigm under Samia Suluhu. In the first paradigm of the late John Pombe Magufuli, he started by following the universal health measures recommended by WHO, by closing school, university, prohibiting public gathering, unnecessary public gathering. But later on, he turned his back to the WHO rule measures or recommendation and started following the natural way, what we call the unscientific way of dealing with COVID-19. He just opening the schools and universities, and all activities was running as usual, and people were not afraid anymore, and they are not afraid anymore about COVID-19. So according to that situation, and people were there was no worry about the COVID-19 about them. But during the Mama Samia Suluhu, when she started ruling or receiving the government from Magufuli, he started implementing, aligned with the universal health measures, including wearing masks in the public gathering, washing hands, etc. Now, how does it look like in the community? Now, in the community, there's different people of group perceiving different about COVID. There are some of people believing COVID-19 is normal illness or disease like any other disease. For example, malaria, typhoid, and it is not the dangerous disease like cancer and diabetes. And therefore, no need to worry. Some believe COVID-19 is not existing in the village. It is for town area, and therefore people in the village should not take precaution. It should be done in town areas. And this is because of lack of testing equipment from the village, where no community member has confirmed with COVID-19. Some believe it's dangerous disease because it can kill many people in a short period of time. And this group are ready to follow all the protocol recommended. And mostly of this group are the ones who have already see their relative facing this COVID-19 issue. And some are still contradictory due to political announcements made since the first case of imported COVID-19 case in Tanzania. This group are curious and they have a lot of doubts. They need much education to educate them about COVID-19 and how to take measures. That's how the project now intervene to make sure people have the same awareness about COVID-19.
Thank you so much, Witness. I can hear from the varied situations that you're encountering there on the ground that there's certainly some real challenges that you've been facing. And, we want to thank you for your incredible work that you have been doing there. Our next speaker will be Ramula. Again, same question. What has COVID looked like on the ground in communities? You have carried out the Amcc extension. Welcome, Ramula. Ramula is a university lecturer and researcher in the areas of nutrition and sexual and reproductive health. She has a master's in clinical nutrition in 2014 and a degree in nutrition sciences in 2012. She works as a consultant for various organizations where she conducts baseline and endline project evaluations, as well as a situational analysis of project implementation in the area of sexual and reproductive health rights, children's education, nutrition, and early childhood development. Welcome again, Ramula. Thank you so much for being with us today.
Thank you, Sophia. Good morning for all. Well, I want to share the first experience that we had when the pandemic started in Mozambique. I think when the pandemic started, what happened is different with the Tanzania. In Mozambique, when we had the first case of COVID-19, we started to disseminate the information about the prevention in all levels. I don't know if the same in all countries, but the one thing that happened here in Mozambique is the first cases in the beginning of the pandemic, the people are connected a lot of cases with the social states. When we started the activity in community, all people say that no, the COVID-19, it's not problem of the community, it's the problem of the people that have money. This it was the first impact that we had in the field when it was, and when we started to disseminate information to say no, this is not about the social status, but it's the one disease like malaria or like HIV that one person independent of the social state can give, and we take the careful. All these things started in time of in Mozambique. We had a lot of the problem. One thing that we look at when we started with activity in this this project is the fragility of the health system. We look at that in community, all human resource and financial resource was direct of COVID-19. All and other activity like the prevention of malnutrition, of malaria, also of HIV, all activities stopped when we beginning the pandemic. All activities stopped in the field about this. We look this reality when the pandemic started. Now the situation is different. Different areas now can have some support with the government, like malaria and HIV. But for example, we increase a lot of cases of malaria, nutrition, and also of some different type of violence in the field in this first time of COVID-19.
Okay, thank you. I think there's certainly no question that COVID has exposed the fragility in healthcare systems all over the world. It's the same here in Canada as well. So thank you for your work, particularly in all of the areas that you have found yourself being involved in. Our next speaker is Melchiade Ninganza, the Senior Programs and Communication Manager for Village Health Works, Burundi. Melchiade worked as the project coordinator for the All Mothers and Children Count program, which focused on increasing access to maternal and child health care, both through activities at VHW's clinic, as well as within the community through community health workers. Previously, he worked with Village Health Works in communication and community organization, where his responsibilities included producing radio shows, conducting sensitization campaigns, and organizing community members. Melchiade has a BA in history with a specialization in political science, so after my own heart, from Burundi University, as well as certificates in global health from the Johns Hopkins Bloomberg School of Public Health and the University of Washington. So welcome, Melchiade. It's certainly a pleasure to have you here and hear your perspective on what COVID has looked like on the ground as you've carried out the AMCC extension program.
Thank you very much, Sophie. In Burundi, the situation was almost the same with Tanzania because COVID-19 was received at the beginning with too much skeptical from the political leaders, where the disease was perceived as an external thing, not really a big issue in Burundi. And at the beginning, leaders were not really giving enough information on COVID-19, including people tested positive. It has been a big challenge in Village Health Works work and the other NGOs as well. In Village Health Works catchment area, we work in a rural area at 90 kilometers from the capital city of Burundi, Bujumbura. We are in the mountains where people are mostly uneducated and illiterate. So most of the information they receive are from one-to-one, from mouth information. They don't read, they don't get much information from books or newspapers. At the beginning of the pandemic, it was not a big concern for community. It was seen as a disease for people in the city, people who travel a lot, who go outside Burundi, and they were thinking that it's not a big issue for them. But with village health workers' effort and the community health workers' effort, we tried to raise awareness on the disease, that people should take seriously that disease and understand how it is transmitted and how it can be prevented. However, in December 2021, the number of cases have been, we saw so many cases of COVID-19 in Burundi, and the people were there has been too much concern in people in Burundi, thinking in our catchment area, people were thinking that this is the end of our civilization. This disease, we don't know how to handle, how to deal with that. But with the support of village health workers, it has been, they have been able to handle the disease, to test everyone who wanted to take the test of COVID-19. However, on the other hand, we had to deal with other health conditions we have in our catchment area. We have a lot of cases of malnutrition. We have a lot of cases, we still have a lot of cases of danger signs of pregnancy. So it was a bit difficult for village health workers to handle COVID-19 pandemic and also keep working on different diseases at the same pace. We learned a lot from this situation. We learned a lot from that pandemic, how to adjust our strategies, how to respond to community needs. We learned a lot how to make sure that we are limiting the number of people at the clinic and at the same time responding to the community need. Community health workers have been very helpful in such situation because they were the one who convey the information to people in the household by household, and also who help people to make sure that they are respecting prevention measure as stated by WHO. So currently, people have enough knowledge on the disease, and on the other hand, they are making sure they understand the prevention measure and they know how to handle the situation, even though it is still difficult on the vaccine to be introduced. The vaccine has been introduced in Burundi, but people are skeptical to take the vaccine because there are still so many rumors around the vaccine, that there are so many side effects, and also the way it was introduced, there has been not enough campaign or governmental engagement to make sure that people are getting the vaccine. Just to give you an example, in Burundi, we have 4 vaccination centers. All of those centers are based in a capital city in Bujumbura, so it's very difficult for people living in a rural, in a remote area to get access to the vaccine. Thank you very much.
Thank you so much, Melchiade. It's interesting to hear, and I think it will be really interesting for our listeners today about the impact that our workers have had and our partners have had on the ground, actually going door to door. And that's the kind of grassroots information that is really so valuable for anybody who's involved in supporting a relief and development charity. So thank you for really contextualizing that for us. I think I've got everybody for the first question. We're not doing so well with our time, I have to say. It's really interesting. I would love to be here all day, but anyway, we'll have to probably try and speed up our next questions a little bit. This next question will be for all 4 of you. We will start with Ramula. And the question is, what has it been possible to achieve through the 2-year All Mothers and Children Count extension? What have been the opportunities and the challenges for the program that has been carried out? And if you could manage to give us some concrete examples, that would be really helpful. Go ahead, Ramula.
Okay. When we started the activity in the field, we started with the disseminate a lot of information about the prevention. How can we prevention the COVID-19 in the field? One challenge that we found in the field, not also in the field, but also in the hospital, in the rural hospital, is the length of material. This project, Amcc Station COVID-19, supports the rural hospital. We say the health facilitator in the rural hospital to give some material for hygiene of the health professional and also from the community. We give in the hospital some masks, some soaps to wash the hand, some product to clean the water. We distribute in the all hospital that we are working in this project. Other thing that was important is we continued all activity that we did in the MCC project with the promote mother securities. Some mothers in the field that work with us with the project to disseminate more information about the prevention of the pregnancy, to take the mother during the pregnancy to the hospital. We continue to this activity during the pandemic. Other thing that we are looking this the first time, and also in the same districts or same area that we are working now, is a lot non-government organization, they stopped the activity in the field when they started the pandemic. In our organization, EHALE, with the support of PWRDF and GAC, I want to say thank you, because during this time, we are not stopped on our activity. We continue all time to support the community. We continue all time to support the health system, and all time, all system, the government of Mozambique say thank you to support us in this difficult time for us. We have some challenge about COVID-19, particularly with this kind of disease we are working, because this disease it's not only related with COVID-19, but other disease also. How can I say? We need to include also our disease or our problem of the community during this period. I think during these 2 years of implementing this project, one thing that we are looking is we lose some result that we achieved when we implemented AMCC project, specifically in the area of violence and the area of teenage pregnancy. These 2 areas, I think, in my vision in the field, I think in these 2 years of pandemic, we reduce our results that we had in the MCC project. I think the challenge for us in this moment is to continue this project of COVID-19, also with the this part of the violence and the teenage pregnancy. I think this is important. Yes, I think that's okay.
Really, that's a wonderful, comprehensive response Ramula. I really do appreciate that. And certainly we have heard similar stories here with respect to increased violence against women. It's a tremendous concern for us in this part of the world as well. I don't know if we have any statistics now on increased numbers of teen pregnancies or not, but this is certainly something that we should.
Yes,
we
yes,
should be-
yes. We have the last report of the organization that work with this is international organization. Before the pandemic, the prevalence of teenage pregnancy was 13%, 13.7, 13.7. Yes, now the last report show 15.
Okay. Yeah.
16, yes, around of 16% of the teenage pregnancy.
Interesting. Okay, well, thank you very much for that that important feedback. Okay, next we will be going to Witness. Same question for you. What you've been able to achieve through this All Mothers and Children Count extension, and concrete examples of challenges and opportunities. Maybe we're having some trouble with some sound issues.
Okay, Sophie?
There you are.
Yeah. Okay. First of all, I would like to say thank you for the PWRDF and Global Canada Affairs for the fund and support during this COVID-19 and through the Amcc project implementation. The achievements during the implementation of COVID-19 extension, including the project has helped in addressing the need of health facilities through provision of medical supply, through provision of PPEs and other materials that supporting health provider in provision of health facility. This has increased a lot of confidence among health providers in providing health services because they have all facilities that is needed for them to provide services. That is one. The second one, in the project area, the project has supported through dissemination of information through health provider, health workers, and through radio program. It has supported a lot in smooth implementation of number of health measures, include vaccination process. A lot of people in the project area, they have the doubt about vaccine has been removed through education provided at the ground. Also, these projects for the government, it has taken as a great initiative for them to integrate their action at the field in the ground. So that's the great achievement. We have numbers of achievements, but this is one of the greatest achievements we have achieved. And about opportunities, now the government have allowed or they have joined the global race of fighting against COVID-19, and they have already trained the lab technician for testing and other health provider for vaccination, but they lack some of equipment, including test kits and other issues relating to mass community mobilization. They call for partners to support their efforts in order to reach the great number of people of the community members in vaccination and testing. And now testing has started from the health centers and hospital, and they have the plan to extend it to the dispensaries. Also, another opportunities you can see as now there is political will from the high level Now they call for all people, all kind of partners to capacity building for village leaders and other community leaders to have the political will to communicate about COVID-19 health measures and other message relating to COVID-19 proper. So they are providing the opportunity for partners and other like-minded organizations to train or to capacitate the village leaders so they can give the correct message to the community. And other issue or other opportunity, as we see from the maternal, since the Amcc implementation, the government or from the project area maternal was in high priority, but due to the government now, they're matching COVID-19 measures. Some of the areas they have given low focus, including maternal and other diseases like tuberculosis. The last time we had meeting with health committees, district health committee of Tunduru, they give us the number of the children who have been tested for tuberculosis and found positive. For example, in Tunduru, where my number, can I check my number? In Tunduru, 229 children, 25 tested for tuberculosis positive, which is equal to 30. Now, we don't know about their family health status. And we see now their family are in a danger or in a vulnerable group for COVID-19. In the aspect of challenges now we are facing, all the school closing and other colleges, we found a lot of children under 18 with pregnancy. So some of them, they could not go back to school because of pregnancy found or because of the pregnancy. And another challenge we're facing is information sharing. As you know, that information increases community engagement. But for Tanzanian, as we know that the COVID-19 information are not shared by the government authority at the proper time. So decreasing the willingness of the community engagement because of they don't see the extent of the problem at the community. And another challenge we are facing, because there is no equipment or testing kits from the village level to the district level. Screening is done at the regional level and at the national level. So now the government have been allowing for testing even from health facilities, but the government lack of the testing kits and other equipment that will support them during the testing. And another issue we are facing in Tunduru and Masasi, there is a very few, it's only Diocese of Masasi that are dealing with COVID-19 issue. Other organizations, they are not focusing on COVID-19 issue. This has been affecting the joint effort in resource mobilization, meeting that will fall as a platform for learning purpose. That's, I think, is the small presentation about that.
Very good. Thank you so much. It sounds, it's becoming remarkable as we hear more and more of the responses from our speakers today about how many problems that we have all over the world that are similar, including Canada. Information sharing is a problem here as well. Lack of testing kits seems to be universal. You know, we're certainly in a similar situation as you are. So thank you very much for that very excellent feedback. Next, we'll have Bart and then Melchiade. Same question. What have you been able to achieve? So you're obviously going to be giving us that overview context from our various programs, as well as programs and challenges that you have encountered in your work, Bart.
Thanks, Sophie. Yeah, I mean, so when the AMCC project was first conceived, it was 2016, and a fundamental aspect of any proposal development process is developing a good risk plan, contingencies. How do you work around different externalities? Could it be civil conflict? It could be a rapid devaluation of a currency, the kind of things that you normally expect. You don't typically, historically, plan for a global shutdown pandemic event and what you might do in that context. And so what we had to do with AMCC, which began as a maternal, newborn, and child health project, subsequently evolved throughout its implementation into a program focusing more on sexual reproductive health and rights, is to take that project and then pivot it to pandemic response and supporting facilities and frontline health workers in managing essentially public perceptions of the pandemic, but also educating people about the pandemic and how they can keep themselves protected. So what essentially happened was a program that had very different goals shifted into one that had extremely different outputs for the last 2 years. What we were able to maintain, and that's been pointed out by both Ramula and Witness, is our network of community health workers, which were always the frontline vector for any health information in AMCC. We're always the primary vector to encourage people and refer people to attend health clinics for antenatal care, postnatal care. And when the pandemic first hit, we did have some of these challenges that were highlighted, certainly political challenges, which we are not unfamiliar with here. There's something going on Parliament Hill down the road, as I understand it, which really threw a wrench into our ability to effectively acknowledge the challenge of COVID-19 and deal with it in sort of a proactive, pragmatic way. So, we were working essentially against systems. Sorry, my robot vacuum decided to address me during my conversation here. But all to say that there have been significant challenges in trying to maintain the gains of the AMCC project, but knowledge is retained and it's not lost. And all of those frontline workers are the same frontline workers that have been working with the project since inception. But I mean, on a professional level, I have been isolating since March 2020. I was actually recalled from the field. We were lucky in that we were able to finish our final primary data collection processes for AMCC after the first 4-year chunk before it completely shifted towards a COVID-19 project. So a lot of other partners, because Global Affairs Canada's reporting often ends with their fiscal year, which is March 30th. March 30th, 2020, you had a lot of organizations scrambling for information and couldn't have access to it. And what this has really highlighted is the importance of not just investing in frontline direct programming, but also in the supportive systems that allow us to measure and monitor that programming. So investing in facility measurement processes, digitization of records, improving access to those records. So in the event this happens again, we have quality information that we can rely on. But it's kind of a chicken and egg situation, as much often is in this scenario, where it's really difficult to plan for that in advance. Thankfully, I think with this partnership, we've been working with these partners from well before the AMCC intervention, and so there's a good, transparent trust bond between all of us, which is really, I think, fundamentally important. The importance of strong partnerships and being able to discuss these things earnestly and identify these challenges is extremely important. From a practitioner's perspective, I have to wrestle with the ethical dilemma of, I'm not going outside, so am I going to send people door to door to collect information from other people? It seems there's a conflict there, and yet I have my partner saying we're ready to go. We are doing this. We're doing it safely, but what we need to kind of acknowledge is we have a social safety net here. We're able, or we're afforded the luxury, if we can, of working from home. And in a lot of contexts, in the places where we work, the opportunity cost of isolating is not putting food on the table or not meeting your basic human needs. So it's a very different context, and it's difficult to wrap your head around it just coming from the Canadian context in which we're living. So I think Ramula also pointed out there are certain things that and trends that worrisome trends that have been exacerbated by the pandemic, by increased isolation, by limited social mobility. You see an increase in sexual and gender-based violence, and which has always been, there's always been a challenge with the visibility of SGBV in these communities, but you're seeing it more and more as community health workers enter into these communities. So the second year of the COVID-19 pandemic response actually included purposeful funding and training for community health workers in safeguarding and reporting on sexual and gender-based violence. So we're still learning throughout the course of this pandemic, but a lot of it is still reliant on the continued efforts of the people on the ground. And I hear you guys thanking us, but ultimately we really should be thanking you guys for what you're doing and the work that you're doing on the ground. It's so important and so meaningful. And the context in which you're operating is so vastly different. When we think of for example, we don't validate the Sinopharm or Soberana vaccines from China or Cuba here, right? But a lot of the COVAX vaccine facility is distributing those vaccines. So if you think about the political challenges we have here, choosing to use the approved vaccines here, and then you extract that to another place where they have access to all these other vaccines that, Western media outlets are saying maybe aren't valid or aren't functional. It actually, there's more of a political influence on the decision to say vaccinate in that context, and it's a lot more nuanced and complicated. So it's been fascinating really learning from partners in this context as we've been unfolding our program and evolving it over time.
Super interesting perspective, Bart. Thank you for that. And the one thing for me that you've really underlined is the importance of being nimble. We have to be able to pivot. What COVID-19 has taught us is that we have to respond. And as PWRDF, as an organization, I've been involved for a short period of time, relatively speaking, but as an organization, I have seen them be very responsive, very nimble, and turn on a dime, whether it's, providing that extra COVID extension care for All Mothers and Children Count program, or responding to a fire in BC, or now we're sending emergency PPE supplies to northern communities, northern Indigenous communities. So it's that, as an organization, you've really underlined the importance of that kind of way of thinking in order to be effective in providing that compassionate care all around the world. Our last speaker on this question is Melchiade. Thank you, Melchiade. And again, we're just chatting about the what you've been able to achieve from this COVID-19 extension program for the All Mothers and Children Count, and opportunities and challenges. So thank you, Melchiade.
Thank you, Sophie. We've been able to achieve many things. As you know, with the beginning of COVID-19 pandemic, funding streams dried out for so many organizations, and we may not be able to respond to that pandemic if there were not support from PWRDF and the Global Affairs Canada. Thank you very much. We were able to provide PPE to our staff and to community members because given the economic situation of many people in our catchment area, they may not even be able to purchase a mask or a hand sanitizer to wash, or soap to wash their hand when it's needed. So the project was very, very important to support us in this area, and also to keep community health workers motivated and equipped when they are conducting those health education. It was very, very important. Also, Village Health Talks is equipped with a PCR machine, which was purchased with the Amcc project. And therefore, it was selected among the testing center of COVID-19. So this was very important. At least people living around Village Health also got a chance to get tested, to get a rapid test and a PCR test if needed. We learned a lot from this pandemic. The opportunity. Let's talk about opportunities. As we were trying to reduce the number of people at the clinic, we learned that we can go to the community with some services. For example, for malnutrition supplementation, there are a group of people who need unreached porridge for supplementation. We decided not to ask them to come to the clinic, but to go to them in community with the porridge they need. It was very, very important because we realized that besides of limiting the number of patients at the clinic, we reduced the distance people have to walk from the house, from the village where they live to village health works. So we realized that with that approach, we can reach to as many people as possible. We had also so many challenges, including the level of understanding of community and rumors around the disease. It has been challenging for ourselves and the community health workers who are our frontline workers to make people understand the disease and apply the prevention measures. Yeah, that's it. Thank you.
Community awareness piece is something that's so important in this pandemic and has really cleaved apart communities and families even. It's been a tremendous challenge. Okay, so we're moving on to our last question. And what I'm going to do for this last question is I'm going to have Bart go last because he gives that umbrella view, that bird's eye view, and can maybe pull together some of the comments that he's hearing from some of the different partners. The order of the panelists will be Witness, Ramula, and then Melchiade. So our question is, how has COVID-19 changed partnership as both a principle and as a way of working? And give concrete examples. So Witness, you're first, and then we'll move on to Ramula after that.
Thank you, Sophie.
Thank you.
In Tanzania, the way of life has not changed at all. And therefore, our partnership, I can give some concrete example from the government level. From the government level, it has increased a lot of partnership and cooperation and collaboration because this initiative, it is one of the most respectable initiatives from Tulu and Masasi, because no any other organization or initiative working directly on COVID-19. In terms of other like-minded organizations and NGOs and SCCOs, because MCC is the only project working direct on COVID-19, it has reduced our cooperation. For example, we had meetings discussing about how the community behavior change, but currently, because we are the only one organization working on that, and the other organizations are not focusing on COVID-19, know that joint meeting or joint efforts in fighting against COVID-19, because they see it's not the area of their focus. But in terms of partnership internationally, including with PWRDF, we have the tendency that every year we receive visitors from PWRDF to evaluate for lesson and sharing of knowledge. But currently, because of their lockdown, they can travel, you can see them here. So
Sorry,
how
sorry.
it's affected us with us.
Sorry, witness, the sound is not going so well. I'm wondering if you wouldn't mind just closing your video off. Although we do love to see you. Seeing our partners is so important to us. But unfortunately, it's just a challenge to hear. Thank you so much. I'm sorry to interrupt.
Okay, so I'm gonna start from the beginning, isn't it?
Okay.
Okay, have said that in terms of partnership and both principle and way of working, at the government level, there is increase of cooperation between the project and the government, because this project of COVID-19 response is one of the respectable and the great projects for Tunduru and Masasi. So the way of collaborating and partnership with the government has increased. But for other organizations, SCCOs and like-minded organizations work in the area of, there is no any other organization working in the area of COVID-19, the district of Masasi and Tunduru. This has affected the joint efforts that enhance collaborative planning and intervention that speed up awareness raising and resource mobilization at the community and joint meeting for lesson learned for improvement. In terms of our partner, including PWRDF, we have the tendency to see them every year in our country for evaluation, monitoring, for sharing lessons. But because of the lockdown in their countries, we can see them as we used to see them and sharing the lesson directly, but rather we use a lot of Zoom meeting and other kind of communication. That's all about partnership.
Thank you. And you have also underlined what we were referring to in the last discussion about how important it is to be nimble and change and to be able to continue to communicate so that we can have those evaluations and find out the best ways to support you in your work. So thank you so much for everything that you're doing. Next, we will have Ramula.
Oh, yes. Well, in Mozambique, I think I'm looking at this partnership of this project, the extension of the project of COVID-19 extension, make more strong the partnership between EHALE and the government. Now I'm looking that now we have more action directly in the government. Our participation in the meeting, for example, in the definition of the strategy in the district are more strong now after this our intervention. The government look EHALE now with different here now. The division of the government now is different because we respond all the change that the health system had in the beginning of the pandemic. Other thing that I'm looking now is the allocation of the material, for example, in this project was more transparent. Because all material, for example, we are looking directly in the hospital, the rural hospital. This was the strategy of the government. They said as no, you take the material and give the professional in the rural area, not with the other project that we take the material. We need to present first in the government, the provincial government, other take material to the district level, and then we take the material for the rural area. No, in this project, this station, we all take material directly from the community. About the PW, I think we had now the more quicker communication, and we have the support during this period. I remember that we sometimes have some documents of the government to say, oh no, we need some medical support. Please talk with the financial to it's possible to give us this type of material, and we write one quick email from PW, and they answer very quickly to say yes, we can include this material in the list of the equipments. I think this communication for us was more important, because sometimes we are looking some strategy of the project. For example, we need the mask, but in the field, in the hospital, for example, the fridge to preserve the vaccination is broken, and they write the letter, please, we need to help to take the freezer to manutention, and all this kind of helps the EHALE respond positive. I think this communication for us was important. I want to say more one time, thank you for PW and DAC for this support.
Oh, bless you. That's very kind. But I think I agree with Bart as well, that we need to thank you for your work on the ground. It's we can't do this without you, and we're just so appreciative and grateful for our partners' work. Thank you for being so concise and describing what you're seeing there and how your partnerships are working. Our last speaker before Bart's summary will be Melchiade.
Thank you, Sophie. In terms of partnership, COVID-19 changed everything. Most of our activities shifted from physical meetings to Zoom or Skype meetings, as we have our colleagues based in the US and our other partners, including PWRDF. It has shifted how we used to work previously. And we had a question we were asking ourselves, since the pandemic don't prepare, it hit when everyone are not prepared. How are we going to sustain our activities? How are we going to sustain what we achieved so far with this situation where there is problems of funding and everything? And like, for example, for masks, we decided that maybe we can make a mask ourselves with our saving cooperative, and then make sure that we are supporting our cooperatives and they get masks at very, very low cost. It was we were also partners were very, very supportive in during that period, because it was we had a quick response for so many things. That's how we end up getting materials necessary from PWRDF and other partners who are supporting village health works. I would say that it has been very, very challenging, and also we learned from that period how we understood that nothing is granted forever. Everything can change at any time. How can we survive in such situation?
Thank you. Yes, you've again underlined how we've shifted and been nimble and gone to and tried our best to be independent. as we can in terms of making our own masks. Okay, Bart, we've got about 5 minutes before we go to our open session. So thank you, Bart, for bringing your experience to this question and helping us contextualize the partnerships that we have on the ground. Go ahead.
Sure. Thanks, Sophie. I think it's important to just acknowledge that partnership's always been central to what PWRDF does. We've always operated through a trusted network of global partners, and it's having that those important relationships in place that have allowed us to really be exceptionally dynamic in responding to changing needs within the context of the COVID-19 pandemic. And I think you got some concrete examples there from Melchiade, Ramula, and Witness that, you know, when something changes and there is a prevailing need, they've been able to openly communicate that to us, and we've been able to pivot and change programming activities pretty quickly. And I think giving partners the agency to make those decisions, historically, everyone talks about the importance of grassroots development and participatory development, but there are still a lot of rules, regulations, and parameters that restrict our ability to give partners sort of full license to dictate what a program looks like. And PWRDF's always sort of pushed against that and aspired to really give partners a lot of license to dictate, you know, what development looks like, and to really fold in community perspectives, Ministry of Health perspectives, and requests into our communications back and forth to make sure that our programming is responsive and meets those sort of evolving, changing needs, which at this point in time are, of course, evolving so rapidly as scientific information comes in, as vaccine access parameters change. But I think also, you know, this has highlighted the importance. I mean, there's a prevailing dialogue in the sector, the international development sector in general, about decolonizing aid, about localizing programming, and what does that look like in fundamental applied practice. And really what it means is putting, again, the reins in the hands of those who are living or have that lived experience and have that local insight and knowledge as to, you know, what local priorities are on the ground. And as you can see from this discussion, the context is so different from what we have here in Canada versus what we have in each of these countries. I mean, when we think about the politicization of things, obviously that's very prevalent here, but it is in all the countries in which we operate as well. I mean, I think, Sophie, you pointed out, you know, the importance of being dynamic, but, you know, in concrete terms, you know, I think that means we need to look at a couple of systems, the way we work moving forward, you know, better secondary data systems, investing more in health management information systems and facility data collection. So we have quality information. And not only do we have quality information, but people on the ground have quality information. Ministries of health, ministries of education have access to quality information that allows them to make you know, important domestic decisions moving forward. Also, you know, I mean, I remember when Zoomer used to be a pejorative term to refer to someone in Generation Z. Well, look at us all now. We're all Zoomers. We're all on Zoom pretty much every day. Technical challenges, you know, improving interconnectivity, improving 4G networks, improving access to one another is super important, and will also in the future, I think, cut down on logistical costs associated with travel as we can work more remotely. I think initially with the COVID-19 pandemic, a lot of people thought, well, can we really work remotely? And in the context of partnership, what does that mean? What does that look like? And I think we've been remarkably successful. It hasn't been without its blips, and, you know, you're on mute. You say it every week. But you know, those realities that we've adapted and adjusted, and I think have been able to find a real proactive, positive way to work with one another in a way that I think actually has pushed our partners to connect more with the existing institutions and systems on the ground, like Ramula was pointing out. Being deeper connected with Ministry of Health means they have greater agency to make decisions that allow us to work with facilities, formal health facilities, which again stand there beyond the length of any established project, which by definition has a beginning and an end. And when we talk about sustainable development. We don't want to pay lip service to it. We want to make sure we're working with the institutions, the systems that will be there and are ethically and morally obligated to continue to serve people beyond the length of any established project. And I think we've been able to do a lot of that. I think just in general terms, COVID-19 is really a test of human resilience. I think in many ways it tests humanity's ability to respond to a globalized, indiscriminate, existential threat. And I really think that there will be a ton of lessons from this whole process that we should explore vis-a-vis climate change, which is the other prevailing existential global threat that we all have to have something to do with. You know, it's a really interesting time and a test for PWRDF partnership, but I think we've come out stronger at the other end of this whole process. And you know, it's obviously a real challenging time for all of us, but I think also when we reflect on this, opportunities like today, you know, taking more opportunities to highlight our partners, to put them to give them a spotlight, to give them a microphone, to engage in this dialogue, so we can ask questions of them and all have you know, a more holistic sense of what this pandemic means in different parts of the world to different people. I mean, fundamentally, I think partnership is about reciprocity. It's about trust. It's about you know, respecting one another's agency. And in this context, we couldn't be more grateful for the work of our partners in this trying and difficult time. And also pushing us outside our, you know, our collective bubbles as we operate here in Canada to really fundamentally try to understand, you know, how this pandemic is affecting different populations around the world. So it's really been a real pleasure, and it's a continuous process. It's another process that influences our learning on what partnership can be and how it should evolve moving forward.
Excellent. Well, certainly, I can't agree with you more, just in terms of the silver lining aspect of what we've got right here, right now. To have these speakers right here, right now is just tremendous. It really does help us all have a better understanding of the work that is happening on the ground. And there is nothing better than that. And you know, this is indeed a real silver lining in a COVID cloud. So I'm very grateful, and I know that all of our listeners are very grateful to have this opportunity. I loved what you said about decolonizing aid. That's so critical for nations around the world, ever more so now than it has been before. And we see it also on aid that we provide in our own communities. Anyway, so we're going to be going to some questions now. We have about 12 minutes left. So the first question comes from Justin. Is there a call to action for the audience? How can we unlock funding from government to ensure we maintain these gains? So that was part of what the Amcc extension program was all about, was to maintain the gains that we had in the All Mothers and Children Count program. It's a challenging question because we could probably have a full weekend of discussion on just that point. But I think that in terms of, you know, advocating for international aid and vaccine equity is certainly something that we can do and that we are doing. We do have the vaccine equity specific fund, but I'm wondering from either of any of the panelists that we have here today, do you have a response to that, just in terms of what we can do to help unlock funds? It's a tough question.
Sure. I mean, I can kind of respond to that. It's really challenging. When you talk about, you know, where should our government invest its discretionary funding, international development is often one of the first things that people say, not there. We need to focus on our own problems. And this kind of pervasive nationalism that exists especially with regards to vaccines, is I think something we do not talk enough about.
Mhm.
Like, we're giving people 4th boosters at this point in time in this country, and the vast majority of the rest of the world is unvaccinated. And if we truly believe that the vaccines will help curb the spread of COVID-19, we should be trying to get vaccines in every arm we possibly can, as many as we can, not 4 per white arm, but let's get 2 in every arm in the world. Because as it stands right now, if you understand virology at all, this vaccine will evolve. And it will evolve in an unvaccinated population, and it will spread, and it maybe will be vaccine resistant at that point, in which case we go back to square one. And I don't think anybody has an appetite to go back to square one at this point in time, which means eventually it becomes the point where we just give up and we say it's endemic, we're gonna deal with it. And that's kind of where we're getting right now. I just worry that it could evolve with some very dangerous symptom. And so I think we really need to focus more on, what does a virus act like? We have to look at the science of how virology works, and then take the science that we have that we're trying to use to fix this problem, and make sure we're effectively spreading it around, and getting it in arms. I think that's super important. Now, that's just a personal perspective, as it would be, but when you interact in a global context all the time, and you see some of the challenges with just access to vaccine, or in a lot of these countries, it becomes kind of frustrating seeing our local response, and being so insular, because this is such a global challenge.
Yeah. Okay.
I just, sorry, Sophie, I'm just going to jump in because Barbara Metcalf had a question that was directed to me, and I wanted to make sure it got answered. She just wanted to clarify about the Vaccine Equity Fund that PWRDF has, that she thought it was funding education and infrastructure, and not so much actual vaccines, and that is correct. We are supporting the ability to get vaccines into arms. And so it's everything from education, community education, transportation, community health workers, etc. I think the conversation here is a bit broadly more about advocating for vaccine equity in general, and for international aid in general. Hope that helps.
Thank you for that, Kim. I could see we've got a question here from Rosalind McGregor. I'm not clear on how much access there is or isn't to vaccines. Who would like to take that one? Maybe we could have one of our partners respond to that one. Ramula, how about you? Since you're well entrenched into the healthcare field.
Sorry, Sophie, can you repeat the question?
Yes. How much access do you have to vaccines? Is there an awful lot of people who want vaccinations and a very limited supply? Or do you seem to have a...
In Mozambique, the process of vaccination started in March of 2021, last year. And first, the program of the vaccination started with the health professional. Now we are in the level that the people more than 20 years can take the vaccination. The vaccination are distributed in the all area, in the rural hospital and also in the urban hospital. We have the groups of the small, how can I say, small. They take the vaccination from the community. In Portuguese, we say brigada. I don't know in English, but the health system, the health system take the vaccination from the community in small group. The range of the vaccination, it's not a lot, because we are all depend of the duration of the donative of the vaccination. We are started to include more groups for the vaccination, but we have the vaccination in different level. In the rural, in the urban, in the city, we have the vaccination.
And similar to us, you're distributing by different ages. I'm not sure, Bart, if you had I saw your hand. I'm not sure if you were just stretching or if you had, no, okay, good.
No, I'm checking chats and stuff. I'm on my phone here. Sorry about that.
Okay. All right. The next question is for Melchiade from Deirdre. Has the funding helped with your group's relationship with your government during COVID, like it has for the groups in other countries?
Yeah, I may say that it helps, but not that very much, because the way the pandemic is managed in Burundi, it's not, informations are centralized, but interventions are not centralized. As I said before, let's take an example of the vaccine. Vaccine is available only in the capital city, in Bujumbura, in 4 centers, in 4 health facilities. So anyone up country before getting vaccine can just need to travel to the capital city, which is not easy for so many people. And there is a national committee which is handling the pandemic, taking decisions, and NGOs are not part of that committee. It's mostly governmental. So there is actions which are happening at community level, and there is also the decisions are made at a high level, at the governmental level. So Village Health is working at community level. We are working at community level with community members that dealing directly with the beneficiaries, and there is no much improvement in working closely with the government on that point, even though we inform regularly on data, on tests carried out, and also even though sometimes we are given some reagents for testing. So that is the current situation of yeah.
Thank you. All right. Couple of last quick questions. If you do have other questions following this that we're not able to get to, please feel free to write into PWRDF, and we'll certainly try our best. We will also be sending out the recording, so you can certainly have another listen to find out if your questions might be answered in some of the conversations. So from Chris Farrow, what are the vaccination rates in the AMCC countries? Maybe Bart, you could respond to that.
Yeah, thanks for your question, Chris. Currently, it's sub 10% in all 4 countries. It is as low as like, I think I cannot recall, but I think I mean, Witness, you might have a better idea in Tanzania about where it's at. I think that's lowest, except in Rwanda, actually. Rwanda, who's not represented on this call, their vaccination rate, I believe, is getting close to 40% of people with 2 vaccines in 1 arm. Rwanda's highly centralized, and if you've been to Rwanda, you'd be surprised at how significantly evolved their health infrastructure is in that country. So it is slightly different. They have stronger procurement networks and distribution networks. I mean, a big challenge has been cold chain management, which means in a lot of the countries, making vaccines available at very rural areas has been extremely challenging. So in Tanzania, for example, the vaccination rate in Dar es Salaam is like light years ahead of where it is in the rest of the country at this point in time. A similar case in all of the countries in which we work. And maybe actually, Ramula, you might have a better concept of sort of what the rate of vaccination is like in Nampula, because you're the only one here who's sort of living in an urban center.
Okay, you're muted, Ramula.
Oh, yes. We have some data here from Nampula about the vaccination. Now we are around of 4% of the population Mozambique.
Okay.
Yeah.
So there's quite a range from 45 to 4%. That's quite a big spread. The last question is a really important one, but sorry, we won't be able to get to this last question, but I am going to talk about it because I think it's something that we all need to be thinking about it. It's from Shireen. How do they prevent community health workers from suffering burnout and stay engaged? So we are at our time now at 12:30. And we've got another question here. Maybe what I'll do, Janice and Kim, if it's okay, is have some comments to go back along with the recording. Would that be all right? Because otherwise we're going to extend beyond our time.
Perhaps we can do that. I'll just, if you don't mind, just wrap up and say thank you to everybody. Let everybody kind of go on, and we will do our best to answer some of those questions that have come up, but we do want to respect time. So thank you so much to Ramula, Witness, Melchiade, Bart, and Sophie for such a wonderful, engaging conversation. It's been great. Thank you also to Elizabeth, Kim, and our friends from the Ontario Council for International Cooperation, who partnered with us on this as part of their Global Citizens Forum. And thank you all for coming. It's been fantastic, and we will be sending out the recording and perhaps trying to answer any questions that we didn't get to. But thanks again for all of your interest.
Thank you, Kim, to you as well. Of course, you can't really include yourself in that thank you, but you're integral to this whole process. So we really do appreciate everything that you continually bring forward for PWRDF to keep us all moving along. Thank you, everyone.
Thank you.
Thank you.
Thank you.
Yeah.